Dupree, one of the leads in respiratory on the day shift. I think I know most of y'all probably know me for coming back here and starting BiPAPs and vents and things like that. We're going to go over the BiPAP today and the ventilation. We have two machines that we use back here. This is called the V60 and this is called the C1. This machine in particular can convert from a vent to a BiPAP. This one only does BiPAP. Well, what does that mean? When you say BiPAP, the patient must be breathing spontaneously. If they have no spontaneous respirations, BiPAP or CPAP is not the mode or machine for them. They have to breathe spontaneously. Ventilation, on the hand, if we go to a vent where they're intubated or a trach, they don't have to breathe spontaneously. We're managing that for them, okay? So this machine does both. This one only does BiPAP. So what's the difference between the two? Well, we have different exhalations on each one of them. And that's where it comes for respiratory to come in and put the proper mask fitting on them. We have different size masks. It comes in small, medium, and large. Well, how do you fit them, right? Because I know a lot of times we keep some in the supply room, but for you or me, there is a little diagram on here in this kit. When you open it up, it just opens like that, and inside this kit, there's a diagram in here that will tell you what size mask they're going to go on. I do it pretty easily because I'm so used to putting it on patients. So we would take this thing and we would fit them on like this, and we could figure out the size mask. And also some of the older masks would come with a diagram on the outside of it. But we do have small, medium, and large. We do not have an extra large. And I know there's times where the mask looks like it doesn't fit. Well, this is the largest mask we have here. So that's what we do with that. Okay, so let's go to the V60, because this is the more simpler one to use. You can do CPAP, and you can also do BiPAP. So what's the difference? CPAP is more of a continuous pressure. It's for oxygenation, for like if you have an obstruction, like the tongue is in the way, it pushes that out the way, okay? So it doesn't give them any ventilation help at all, but it does give continuous pressure where it keeps the airway open, and it also keeps it where you can oxygenate the patient. So what's the settings? Well, we have many settings for CPAP. A lot of people wear CPAPs at home. They tell you, oh, I wear a CPAP at home, correct? Well, that is based on what a sleep study has done for them. But here, if we're having a problem with oxygenating the patient, we can manage by figuring out a pressure that would help oxygenate them. On this machine, you would read it here, and it would say CPAP of 8. That's the amount of pressure you're actually giving them in centimeters of pressure. FiO2 is one of the things, of course, because to keep them oxygenated, we need oxygen, correct? So you would dial in whatever the patient needs to oxygenate them, anywhere from 21 all the way to 100%. That would be dialed in by hitting that button, hitting these little arrows, and dialing it up. That's one thing you guys do back here. If you see them desaturating, you can up that amount. It goes all the way up to 100. You can hold it down, and you would then hit accept. Then you would have 100% oxygen. The pressure itself, I would let respiratory manage that because we're more familiar with the pressure that we apply to patients here at Methodist. So this number we would manage. Of course, you guys can change the oxygen, the FiO2. If you see them desaturating, we put them on, respiratory's left to go do something else. You can up that oxygen by just pressing that button, hitting the arrow, and hitting accept. Then you would call respiratory lead, and you would get assistance with that if you need it. Always call on the Vocera for respiratory lead if you have any questions after we apply this machine to them. Well, there's two settings, CPAP, and if you can also go to BiPAP also. That would be my ST mode here. Now, BiPAP is a little different. You know how you get the COPDers back here that have high CO2s and they're not waking up? This would be the mode for them. You can oxygenate and blow off CO2 at the same time. Where CPAP, you're not blowing off CO2, you're just oxygenating. This one would do both. This number at the top, the IPAP, is what blows off the CO2. This number right here. Applying it, that's something respiratory would know what numbers we need to use from experience. I know some people need high numbers, some people don't. Depending on what that CO2 is, that number would be an indicator to blow that off. The EPAP is like CPAP, just giving a peak, a pressure. This number ventilates to blow off CO2. The number at the bottom actually oxygenates, just like being in CPAP mode. So this is the mode you would put on someone who comes out groggy, or we find out he's COPD, correct? And we think his CO2 is high. I know you've heard that back here before. This is the mode we would do. The other mode, oxygenation only.
What's the usual?
With the what?
What's the usual IPAP pressure for the
standard?
Yeah, the standard.
Oh, anywhere from 10 to maybe 14 or 16, depending on the patient. That would go by, we would have to look at the size of the patient, his blood gases. Suppose you have a CO2 in the 80s, you would go up on this number to blow that off.
The ABGs.
That, yes, not only ABGs, but you know, if you have an indicator of prior ABGs, you have an indicator of his history, or just by looking at the patient, that's something respiratory has experience with, we would have to just look at the patient too, the chest size, what kind of volumes we're reaching by that, because you know, you get a volume. After you apply these, you have a volume there. So if we start this, get that start. Now, of course, it's going to alarm because we don't have a spontaneously breathing patient, correct? Okay, so you would get some volumes on there. See those volumes? This is what you would chart. So first of all, your charting would consist of, on BiPAP, you would have IPAP of 12, you'd have an EPAP of 5, you have a rate, which is a backup rate only. It's not a rate that the patient is going to get unless they're not breathing. It's not going to continuously give them that rate. If they stop breathing, it's going to give them a rate of 14. The oxygen, well, the FiO2 is the FiO2, whatever they need to get the sats up to, you know, anywhere from 21 to 100, and that's that number there. I time, I'm not going to go into much into I time because that's not something you would chart back here, and rise time would be something that respiratory would kind of, you know, regulate back here. I can give you a brief idea. I time is how long it keeps up that pressure. The inspiratory time. So when it administers that pressure, it keeps it up for 1 second. And it says that on there, 1 second. So that helps oxygenate too. Rise time is how fast it's delivered, the pressure. How quick it is in milliseconds. That's something respiratory could do also. But when you're charting, you're going to mainly chart the IPAP, the EPAP, and the backup rate and the FiO2. Okay? Now we're ventilating the patient here. Of course, that's not going to give us a good value because it's not on a real patient. But if I was to chart what the volume was, right now I would be saying the volume is 96. It's 161. That's what the rate is, what spontaneously breathing patient is doing. He's doing 25. 25, okay? Then you would chart practically just the rate, your volume. That's what you would be familiar with. Are you comfortable with that? Okay. So this machine over here, to put it on standby, I want to show you how to do that. You hit the standby button, and it immediately goes into standby. There you go. To restart it, you would press this button. Because we have a lot of patients we take off and on back here. They start having, you take them off, and then they start having difficulty again. You would hit the start button here. You want to put, you start it here, and they miraculously wake up, right? And they're doing really great. And you just put them on a 2-liter nasal cannula. You would put it on standby, and you would call the lead respiratory, tell them they're doing great, and they would move it if it's time for them to move it, or leave it on standby in case you may need it again. We usually don't take it out of the pod until they're actually moved upstairs. And if they need to go up with a CPAP or BiPAP at night, we should have an order in for them to go upstairs. If they have if they wear it at home, we should always keep a order for them to wear it if they get admitted upstairs, because they may wear it when they're here. This machine does the same thing as this machine, except it works a little different. This one converts to a vent, and it does BiPAP also. Well, how do you know what settings? Well, on here it says NIVST. That means non-invasive. That's when you know it's going to work as a BiPAP or CPAP, okay? If it says another mode, and I'm going to show you the other mode when it's on a ventilated patient, but this is for non-invasive. Well, how do you know your settings, right? Well, you hit mode, and This is, you go into non-invasive, which you don't have to do. Respiratory will do that for you. But if you want to know what settings are they on this machine, this one's a little tricky though. Let me explain to you. When you dial in on this machine, this machine, it's easier. The IPAP is what you've dialed in. This machine, the IPAP is above your EPAP. So you would add these two together to get that number. Now over here, we have 12/5. To get 12/5, it would be this. That's 12/5. Because remember I said the top number would be added to your peak. That's how that's done. So if you want to chart something, you would add these two together. That's your IPAP, which is the one over here, and this is your EPAP, which is this number here. Is that okay? You have any questions? So it'd be that number added to that number over your peak. So that's 12/5. Here's 12/5, but except these two are added together. So if someone comes in here, respiratory comes in and sets it up, and you say, oh, you have 7/5, you call me back on the Vocera, right? No, it's added together. It's 12/5. Now there's also a backup rate just like this one. It's under controls. My backup rate is 14. I have a 14 here. That's your backup rate. Backup rate is only if the patient stops breathing. It gives them 14. You won't get it. They won't get it unless they stop breathing. It's a backup. Another thing, eye time. Eye time here is how long it keeps that pressure up for 1 second. We have 1 and we have 1. See, same thing on each machine, except 2 different type of machines. You also have, your FiO2. If I want to dial it up, you go into controls right there and you turn the knob. I would expect you guys can do that, because if something happens back there and you have to go up on it real quick, I will show you how to do that. You tap it, it goes away. Tap it again, you can change it if they start sounding good. You want to go down, you tap it again, you dial it down. I'm going to go down to 70. You can either press it or tap it. Press it or tap it. Press it or tap it, okay? So you can do both. So when you're charting, you would chart 12/5, FiO2 of 70, and backup rate of 14. That would be your charting. Okay? Same thing with here. 12/5, which would be your IPAP and your EPAP. That's BiPAP, right? Backup rate of 14, 100% the patient's on. How do you wean it? Press the button over here. You hit the arrow this way, and you hit accept. Now you're on 82%. This one over here, hit controls, hit the button here, dial it in. You can either press it or press that button there. Are you comfortable with that? Okay. All right. So, 2 different modes. You can do CPAP and you can do BiPAP. CPAP is for spontaneously breathing patients that need oxygenation. BiPAP is to blow off CO2, right? And to also oxygenate. That's the mode you would use for someone who's a little groggy and not waking up as much. But most of the time we use BiPAP back here. We don't use CPAP very often. Alrighty. So, both of them work with they work with the same mask. This one has a mask and this one. So when you're putting the mask on, I would not recommend releasing the Velcro first. Take the snaps off, put it around back of the head. Try to loosen them a little bit, but make sure you keep the Velcro on, because if this Velcro comes loose, it's difficult situating this headgear again. You want to be careful with releasing all the Velcros, because it gets a little difficult to get them back together. See, there's so many. This one wraps around the side of the head, these two here. This one tightens up the back of the head, and this one goes around the neck area and around the cheek, okay? It snaps on each side, snap, and a snap, and it goes around the face like that. It's over the nose and mouth, but when the mask is fitted, it cannot fit under the chin. It has to be right under the lip, right here. This tip fits to the lip area right here. If it's extending over here, you're gonna have too much of a leak and they will not oxygenate well. You have to have a good fit. But of course, we do have large people. The face is larger, but the largest size we have is large. That's the only one we have, okay? This machine is set up a little different. Respiratory knows there's a different adapter, another elbow that goes on this one. It's a little different as compared to this one that comes out the pack like that. But that's something respiratory can work on, okay, for you. There's an exhalation that should never be closed up on this side. See this little thing here? Never close it up. They will retain CO2 like that because it closes up the exhalation port. Normally, I tear it off, so no one makes that mistake. Yeah. They should never put it there. You're right about that. They shouldn't put it there. But this is you gotta be cautious. And you see this little hole right here, and you hear air going shh. You want to keep that open. It's not a leak. It has to be a leak there. You have to have that there. And it's a little hole. I don't know if y'all can see it. See it? Mm-hmm. And I'm sure you've heard it before when we put it on a patient that has that leak. With this one, you can't have a leak at the mask because they exhale through here, through the exhalation port. That's where they exhale. This one does not work the same. It has to exhale through here, through the mask. That's why we have a closed elbow on this one, because they exhale through here, through this exhalation port. You don't have to worry about this little piece because we don't even have it on this circuit. Okay? All right. So like I said, when you place the mask on, it must fit right below the lip, not under the chin, because you will have a leak and they will not oxygenate well. And they won't ventilate well either. They won't blow off CO2 like they should. Another thing, okay, so we convert from a BiPAP to a ventilator on this machine. This one does not do that. Can you put a BiPAP on a trach patient? Absolutely not. I want to tell you about that too. Because what happens with that, it's invasive. This is an invasive device. All of these are. So they must be placed on a patient who has an ET tube when you're using the ventilation part. A trach cannot go to a BiPAP because it's non-invasive. So you have an invasive airway, so you can't put a non-invasive device. So BiPAP, CPAP will not work on a trach or ET tube. Never. That's why I think I got called a while back. We need a BiPAP for someone with a trach. No, we can't do it. But we can put that on a ventilator, right? So on here, we have modes on here, which respiratory would do for you. We would put them more on an invasive setting. So what is the settings normally we use for an adult patient? 4 to 6 cc's per kilogram of their tidal volume, that's what it is. So if you think about it, a normal man would probably get a 500 tidal volume. What was the tidal volume, right? A tidal volume is the amount of volume to expand the lung that this ventilator will give them, okay? A rate, every rate you give them on a ventilator is a set rate. It's not a backup like the non-invasive devices. If they're set on 16, they're gonna get 16 per minute. That's what they're gonna get. They're gonna get that. It's always gonna give them a rate. If you have it set on 500, with every rate, they get 500 of volume to expand the lungs, okay? So if you put it at 450, what are they gonna get? 450. If you got them on a rate of 18, are they gonna get 18 when they're intubated? Yeah, they're gonna get it because it's set with a volume and a rate. FI2 is oxygenation. Now there's such a thing as PEEP. We talked about CPAP, non-invasive, PEEP and EPAP. They're getting that with this too. It's the amount of pressure when they exhale it's left in the lungs after exhalation. We give them that to oxygenate them. So where is it on here? Let's go into mode. We're going to do a control mode ventilation, right? So we're going to give him or her, we're going to give him 500 tidal volume. That's here. This is saying APV-CMV. It's not saying non-invasive anymore. Remember the NIV was up here. Now we're actually giving a control mode ventilation like we do for the trach patients that come here, or people who are coming from ET tube to trach. We put them on a rate because they're normally at the LTAC on a rate, right? So we do that for them. We give them a tidal volume. We give them a PEEP. We give them an FiO2. They normally come in on low FiO2s because they've been on the vent for a while. We go into control. You press that button. And we have a rate here. So let's give them a rate of 16. I time is something respiratory would do. And we have a PEEP of 6. Okay? So if you want to see your settings, how would you chart your settings? You go into control mode like we did. He's on a tidal volume of 500. He's on a rate of 16. He's on PEEP of 6, FiO2 of 50. That's what you would chart. That's how you would chart it. So, it hooks up. We have 2 types of inlines. It comes in a pack like this. This is the pack it comes in. This one's shorter than this one. So they come in with an ET tube, correct? The depth of the suction catheter is how far it goes into the airway by the length of it. See the difference? This one's for a trach, this is for an ET tube. Why is that? Well, the ET tube, you have to go through all the length of the ET tube into the lungs. This one is set in the neck, you don't have as much. You have to use this one for a trach. There's 2 different sizes, okay? So, when we have a trach patient that comes from the LTAC, we use this one. This becomes a regular ventilator. You take this off because this was for non-invasive, correct? This would fit at the end of this, and it would go straight to the trach like that. Okay? Now, how would you start the ventilation? Well, there's a start ventilation button. You would press that. Now the patient's getting 500 tidal volume. They're getting a PEEP of 6, FiO2 of 50. Well, where's the rate? You need to chart the rate. Hit control, and you would be able to see the rate. He's getting a rate of what? 16. So the patient gets a rate of 16 per minute. Every rate he gets 500 of volume to expand the lungs, and he's going to have 6 of pressure left in the lungs after exhalation. All right? And every exhalation is passive. We're not pulling it out. He's passively exhaling. That's how it works with ventilation. Is that comfortable? You got that? Okay. All right. So how do you read your volumes? Well, right here, it says exhale volumes. You would get maybe close. It should be close to that 500. If you don't have 500, something's wrong. To put it on standby, I'll put it on standby for now, and I'll explain that. Press this button, activate standby, okay? Now, suppose you're not reaching your volumes. What could it be? Well, there's several things. There's a leak somewhere, okay? It could be where the cuff is not inflated. You know, there's a little cuff on a tray. That's not inflated. Or it could be out. That's the worst part. You don't want that to happen. Or it could be something loose on the machine. Well, what can come loose? There's several pieces on here. This is called a flow sensor, which gives you all the readings, all your exhaled readings on the vent. This is where this fits, right here. This could be open. One of the tubing could have come apart, or this could be open. There's several things. Respiratory, you call the lead respiratory, or you call respiratory to come up and check it. I would always recommend call lead respiratory on the Vocera. That's the quickest way. Get us to come here and check on it real quick. So basically, for suctioning, there's a little port here on both of these. This little port here is used for saline. If the secretions are very thick, you can put a vial or you can use some of your syringes, insert it here. You're pushing through, and you would put the saline here and push it through and push your catheter in, and you would use saline and suction out. Okay? But that's what this port is for. It's for saline vials, or if I don't know if you've seen the pink bullets that we have around the hospital, or even just the regular saline syringes, you can use that and insert it in there and get it to loosen up those secretions a little bit too. Now, we can transport on both of these devices. There's tanks on the back, okay? Now, just like you hook it to the 50 PSI, and when I say to 50 PSI, there's 50 PSI, that's a lot of pressure coming out this wall. For the flow meter, you have to hook it to the back of the flow meter, right here. Don't ever hook it to the front. That's a flow, that's not a pressure. It needs to hook to the back. If it's not hooked up to the 50 PSI on the flow meter, this machine will not work. I can tell you. It'll alarm nonstop too. You have to hook it up to a red plug to make sure it says charged up. Must be, even though there's backup batteries on both of these, they don't last. They last anywhere from 2 to 3 hours. I would not recommend ever not plugging it in though. It needs to be plugged in, even though. But when you're transporting, you would unplug it, and if you want to transport, unhook here, and it would hook up to the 50 PSI on the tank. That's how we're able to transport people on vents and BiPAP. The BiPAP has the same thing. This hooks right here. On this one, on the back, we take one of the shorter ones and we hook up right here to the 50 PSI, and we transport them on the BiPAP so we can get them where they need to go. Other than that, I think that's it. I mean, I showed you the inline suctions. I showed you the different masks, how to fit them, how to attach it to the face, how both the machines do the same thing, except this one converts to a ventilator if you need it. Is there any questions?